Hi, my name's Toby Hammond and I'm a consultant general and colorectal surgeon at Broomfield Hospital in Chelmsford, Essex. So essentially, for patients who require surgery to have their entire colon and rectum removed, the only option for the stool that's then made throughout the small bowel to exit the body is through a stoma, which is when the small bowel is brought onto the surface of the skin of the abdomen and then those contents go into a bag. If the patient wants to avoid a lifelong stoma, then the end of the small bowel can be turned into a reservoir that could then be attached to the top of the anal canal. So essentially the way the colon and the rectum work is that the contents that are made throughout the small bowel pass into the large bowel, and through the large bowel the contents are essentially converted into stool, which then gets stored in the rectum, and then when the rectum is full to capacity, the individual patient would then choose to evacuate the stool when it's convenient. Of course, once you remove the colon and the rectum, there is no reservoir left. So that's why we have a need to create a reservoir if a patient wanted to avoid a lifelong stoma. So essentially your options are, once your colon and rectum have been removed for whatever medical reason that might be required for, then the patient's option is to have a lifelong stoma, an ileostomy from the small bowel, or we create a new reservoir out of the end of the small bowel and attach that to the top of the rectum. And the purpose, and the sole purpose of that reservoir, which is what we call the pouch, is to store stool contents so the patient can go to the toilet at convenient times. So there are in fact a number of different shapes that pouch or reservoir can be, but the most commonly used and the most commonly employed shape of pouch is the J pouch. In terms of a candidate, really any patient who's had to have their entire colon and rectum removed, there are a number of reasons why that might be, but for the purposes of this interview, what we're really talking about is patients who have inflammatory bowel disease, and most commonly patients who have ulcerative colitis. In a lot of cases, patients will be very acutely unwell with their colitis, and they would have been in hospital for a period of time, and unfortunately the medication that they would have been given hasn't been able to keep the inflammation within their bowel under control, and these are sick patients who need urgent surgery. And in these circumstances, as often as an emergency or as a semi-urgent procedure, they'll have the entire colon removed and a stoma formed from the end of the small bowel, but the rectum will be left in place. And that's essentially the first stage of a three-stage procedure. When the patient's then made a full recovery and they're well, then they will be seen in the clinic by the surgeon who's looking after them and given options as to what they would like to do next. One of those options will be to have the rectum removed, and then the patient can have a permanent stoma formed from the end of the small bowel, or they can have a reservoir made, like a new rectum essentially made, out of the end of the small bowel, the J pouch. And that will be the second part of the procedure. This is because a lot of surgeons will do something called a defunctioning ileostomy, which is where the small bowel upstream from the pouch that's been created is turned into a stoma. So the bowel contents will then go into a bag to allow the join downstream, this is the join of the pouch to the top of the anus, to allow that join to heal or to minimise the consequences should that join leak. And then once the patient's made a full recovery again from that procedure, then they would have the loop ileostomy closed, so that then their pouch starts working and they would empty their pouch, their bowels, in the way that someone who doesn't have a pouch would. So that's the three-stage procedure. In terms of a two-stage procedure, there are two different ways that can be looked at. A two-stage procedure could be someone who's had their entire colon removed as an emergency or as a planned procedure, and then decides to have the new rectum, the pouch made from the end of the small bowel, but not to have that defunctioned with a loop ileostomy. Or it can be a patient who has the entire colon and rectum removed and a new pouch formed at one sitting, but that is then defunctioned with an ileostomy. And then they have that ileostomy closed at a later stage. So essentially it's a patient who has 2 operations rather than the 3 operations that I've just described. In terms of tackling whether to have laparoscopic or keyhole surgery versus open surgery, open surgery is essentially where we make, or as surgeons, we make a large incision on the abdominal wall to get inside the abdomen to be able to do the surgery that is required. Keyhole surgery or laparoscopic surgery means making small incisions dotted around the abdomen, which we put specially designed instruments through to then do the same operation that we would do open, but through just much smaller incisions. And really, therefore, the advantage of keyhole surgery is that the patient has a quicker recovery, potentially, because they don't have a large incision, they just have a number of small incisions, and therefore there's the potential for less blood loss, improved pain post-operatively, less wound infection, and in the longer term, less hernia formation. And sometimes with keyhole surgery, we actually can do more accurate surgery because we have a camera right inside the abdomen, close to the action, and therefore can potentially do more accurate surgery. But really, open laparoscopic surgery, it's the same operation, just done through a different modality. But we tend to prefer keyhole surgery if possible, because it causes less trauma to the body than if one was to do a larger incision, open surgery. Start the operation off doing keyhole surgery, but for reasons such as its anatomy within inside the abdomen or scar tissue having formed within the abdomen from previous surgery may mean it's simply not possible to do the whole operation via keyhole surgery, and therefore we may start through keyhole but then convert to an open operation. But whatever happens, it's the same operation, just done via a different modality. In terms of hospital stay, generally it's a variable length of, or it's a variable number of days that you may be in hospital. It could be anywhere from 3 days to over a week, depending on the patient's recovery, how they manage their stoma if they're given one, and whether there are any complications from surgery. But on average, I think you'd be looking at 4 to 5 days. Essentially, once you've been discharged from hospital, and when you are discharged, you should very much be able to manage your stoma by yourself, which is something you may well know how to do anyway, because you'd had one prior to that operation, and you'll be mobile, up and about, eating and drinking, and your pain should be relatively well controlled. How long it's going to take you to get back to where you were before you had the operation, that's very variable. It tends to be based on you as an individual, how motivated you are, and there are a number of other factors involved, but generally I would say that you're looking at anywhere from 4 to 12 weeks to get back to where you were. If you have an emergency operation or a semi-urgent operation to have your colon removed, in which case you've then got the end ileostomy, the bowel, the stoma made from the end of your small bowel, and you've got your rectum left in place, I would say on average you're looking at about 3 to 6 months, and more along the 6-month mark, before we would want to consider further surgery. This really just allows any inflammation and scar tissue within the belly a chance to settle down and fully resolve. Once you've then gone on to have your rectum removed, you've had the pouch placed, but you've got your covering ileostomy, your covering stoma. In terms of recovery from that, anywhere really from 4 weeks to 3 months is generally when we would look at closing the ileostomy. That's very much more dependent on how you recover as an individual. If you have a 2-stage procedure, again, it depends which 2-stage procedure that you would have. So if you've had your entire colon and rectum removed and a pouch formed all in one sitting, And then you're also given a loop ileostomy to allow that join downstream, the join between the pouch and the anus, a better chance to heal potentially. Then really you're just looking at the time between that operation and when you can have your ileostomy closed. And again, that's as I said before, anywhere I think from between sort of 4 weeks to 3 months. I think that'd be a realistic time. If you were to have the first stage where you have your entire colon removed and your rectum left in place, and the second stage where you have the rectum removed and the pouch formed, but no covering ileostomy, then of course there isn't another time to wait because you don't have an ileostomy to be closed, and the wait between having the emergency operation and the pouch, again, as I said before, you're looking at around 6 months to allow any inflammation and scar tissue within the abdomen a chance to settle down. Okay, so I guess in terms of getting ready, there are two things. How can you physically get yourself ready, and how can you psychologically get yourself ready in terms of what do you need to do to understand what's coming? So I think physically, you just need to be in good shape. If you can exercise regularly, do so. Certainly eat healthily. And really, I think it's just a case of having a good, healthy, balanced lifestyle with exercise. I think that's your best preparation physically to get yourself ready for the operation. In terms of psychologically preparing yourself, I think you really, really do need to understand what the risks and benefits of the procedure are, so you can psychologically prepare yourself for those. And for that, you need good patient resources, and certainly one of the best patient resources that I'm aware of, and certainly one I recommend to all my patients, I'm going to read this, that's okay, is a book that was written by a very senior experienced pouch nurse at St Mark's Hospital in London, which is an excellent book called Ileal Pouch Surgery for Ulcerative Colitis, a guide for patients. And there are other things that you can do to prepare yourself, such as the Crohn's and Colitis website for patients, certainly finding other patients who have had the operation and asking them what their experiences are. I think that'd be a hugely valuable time spent. What are the risks of pouch surgery? I mean, that's a huge question, and it's certainly one that you should go into detail with your consultant surgeon prior to surgery, and they will want you to go through those anyway, so that you're fully informed prior to having the operation. The risks of having the operation itself will involve pain following the operation, the potential for bleeding, infection. An infection can occur within the chest, the bladder, or any of the surgical incisions. Because wherever we make an incision on the abdominal wall, that will weaken the parts that we go through. That does mean there is a chance of developing a hernia at any of those sites. Now, that's not an immediate problem, but it may be a problem in the longer term. During the operation itself, there are a number of structures that we have to avoid during surgery. And if any of those were inadvertently injured or damaged, then that can lead to complications related to that particular structure. There is a small risk of injury to the nerves within the pelvis. Now, these nerves can affect sexual function. So certainly for a man, there may be an issue with developing an erection or ejaculating, and for women, there can be sexual dysfunction issues as well. The nerves to the bladder can be damaged, which can then lead to problems with emptying one's bladder. Surgery in the pelvis can lead to development of scar tissue, which for women can lead to problems with fertility. Now, the development of scar tissue is reduced when you have keyhole surgery, but it's just worth bearing in mind that if scar tissue does form around the ovaries and the fallopian tubes, then that can affect fertility. And therefore, a proportion of women will choose to delay pouch surgery until after they've completed their families. One of the other risks of pouch surgery is that the join between the pouch and the top of the anal canal can leak, and we call that an anastomotic leak. And if that were to happen, that can lead to a prolonged recovery. It can mean that the pouch never fully works in the right way or doesn't work at all. That's one of the reasons why some patients are given a stoma from the small bowel upstream of that join. So if there is a problem with leakage, actually the bowel contents leak into the bowel contents go into the bag rather than leaking out from the join between the pouch and the top of the anus. With all surgery, there's always a risk of developing a blood clot in the legs, a deep vein thrombosis that can potentially travel to the lungs. In terms of how you can expect your pouch to function, in the very early days following surgery, it's going to be a variable feast. Your bowels are going to be fairly erratic. There may be days when you might not go at all. There may be days when you go repeatedly. And it's really going to take a while for your pouch and your small bowel and your body in general just to get used to the rearrangement of your anatomy. By sort of 6 weeks to 3 months, your pouch function should have settled down. And on average, we would expect you to open your pouch 6 to 8 times a day. One of those times potentially during the night. You may get a degree of small volume leakage from the pouch through your anal canal, which can cause soiling. And therefore some patients may need to wear a pad, and this may be during the daytime and during the night or just at night. Patients may also experience what's called fecal urgency following their operation. And this is really a sense of when you feel the need to go to the toilet, that you don't have much time to get there, hence the sense of urgency. That's hugely variable, dependent on the individual. And it really is based on what you were like before the operation, how good your sphincter function was and currently is. It's a very hard question to answer on a generic level, and again, it's something that you might want to discuss with your consultant prior to surgery based on your current level of function. In terms of returning to work, again, I feel that I'm repeating myself quite a lot, but it really is a very individual thing in terms of when you get home and you're recovering from the operation, when you return to work is really simply when you feel able to do so. So when you feel well enough and you've got the energy and you've got the bowel control that you want, well, I think that's when you return to work. And I wouldn't want to put a specific time on that because it is so individual. In terms of how long it will take your pouch to settle down, very variable yet again. I think on average you're looking at anywhere from sort of 6 weeks to 3 months for it to settle into the habit that you can expect it to form thereon in. On average, once your pouch has settled, you can expect to be opening it 6 to 8 times a day. One of those times will be at night, and you may get some leakage as well, which will require you to wear pads. So in terms of what the advantages of surgery are, personally I think it's one thing. The advantage of having the operation is so you don't have to live your life with a stoma. That's the sole function of having a pouch, is to create a reservoir where the stool can sit and then you can empty it at a convenient time. So it's purely to avoid having a lifelong stoma. That is the advantage of the pouch operation. In the longer term, in terms of complications, on average about 50% of patients with pouches will have minor issues that will need some help. There can be inflammation within the pouch, something called pouchitis, and your pouch can sometimes just not function in the way that you would ideally like it to. I think this is what we mean by minor treatable problems, but certainly about 50% of patients will experience that. Overall, I think one has to take into mind or take into account. So overall, one has to take into account that the aim of the pouch is to avoid a lifelong ileostomy and potentially give you a better quality of life than if you were to have a stoma, the ileostomy. So even though 50% of patients may have minor treatable problems associated with their pouch, as long as it's giving them a perceived quality of life that's better than if they had the stoma, then that's okay. And that's what we're aiming for. Are you able to live your life in the way that you want to live your life? Now, there may be some irritations and some complications with the pouch, but overall, do you have a good quality of life? And do you think you have a better quality of life than when you had an ileostomy? I think if the answer to those questions is yes, then that is a success. If the answer to that question is no, well then I think that's a failure, and that's what pouch failure really is. It's when your quality of life with a pouch is so severely affected by the problems you're getting with the pouch that it's just not worth having the pouch anymore, and you're probably better off being back with an ileostomy. And we do say that about 10% of patients at 10 years will have pouch failure, which is, I think, termed as I've just described it.